Transforming care through genomic medicine, personalized therapeutics, health services and outcomes research, and innovations in healthcare delivery. We're Children's Mercy Kansas City, presenting our audio interview series, Transformational Pediatrics, with host Dr. Michael Smith.
There are increasing concerns regarding proton pump inhibitors and risk of fractures in adults, but few studies have actually evaluated this risk among pediatric patients. This is Transformational Pediatrics, the podcast from Children's Mercy. I'm Dr. Mike. Let's talk with Dr. Nathan Fleischman. He's a pediatric gastroenterology fellow at Children's Mercy, Kansas City. Dr. Fleischman, what are the known concerns regarding proton pump inhibitors and, in general, the risk of fractures?
Sure. So, in adult populations, people have been concerned about side effects related to PPIs and especially fractures really for some time, for the better part of 15 years. This has been investigated. In pediatrics, we prescribe these medications a lot as well. So it's kind of a trickle-down effect, and people are wondering, is there a risk of fractures in pediatric population? Well, in adults, this all kind of stemmed from more postmenopausal women and the risk of hip fractures. The initial study that I'm aware of by Vestergaard in 2006 looked at this risk in adults and specifically PPI exposure within a year, and did find that there was some association with increased risk of fractures. Several studies have been done since then, including meta-analyses that have kind of confirmed this. In terms of children, there's really been limited literature. So only within the past kind of 3 or 4 years have there been studies kind of looking at this. And of those studies, most of them have either looked at older children or younger children, not all children, and they have some conflicting results.
Yeah. Yeah. What I know this is not maybe well known, or I know a lot of people are looking into this, but what exactly is it about the PPI that is associated with fractures? Is it simply just loss of mineral, low? Are people becoming low in magnesium? What do you think is going on with the PPIs?
That is a great question, and the short answer is nobody knows. Like you said, there could be a mineral component. Some people have postulated more of a hormonal component or a direct effect on cells that are involved in bone turnover. And so nobody knows the exact mechanism. And additionally, you'll see some differences in adults and pediatrics in terms of maybe how they handle medications, how they metabolize them. So that plays into it too. The other question is it just an effect from the underlying disorder you're treating with the medication? And so all these are good questions, but I'm not aware that anyone knows this answer yet, although there are many theories out there.
Yeah, I know, and I agree. I just kind of wanted to hear what you thought. So now going back to the pediatric patient, obviously you mentioned there was a trickle down effect, right? As more and more kids are being prescribed PPIs, that is a good question, right? Is there that same fracture risk? So tell us about what you actually studied and what was the design of what you did.
Yeah, so our study, what our main goal was, because there's such limited literature out there, is basically to see, does this relationship even exist in pediatrics? We didn't set out to determine cause or anything like that. We basically wanted to look out and say, hey, if a child's exposed to a proton pump inhibitor, do they have an increased risk of fracture? Do they seem to have more fractures? So our study was a little bit unique in that we used a database called the FIS database, which is made up of more than 50 children's hospitals across the United States. And so we have access to pooled data, which gives us a lot of large numbers and encounters in various settings. So emergency departments, inpatient settings, surgical settings, and observation settings. And we track children. So we look to see, does this child have exposure to PPI based on kind of what they were given while they were in that hospital encounter? And we track them over a 2-year period of time to see if they had an incident of fracture being coded. And so we went back and looked to see, the patients that were exposed to PPI, what percentage of them had fractures. And then we did a control group by taking children who matched up pretty closely in terms of demographic factors and location of their encounter. And we tracked them over 2 years and looked to see, if they weren't exposed to PPI, what was their fracture risk?
Yeah, so very interesting, right? So here you're simply asking the question is this same association with PPIs that we see in adults with fractures, is that same association happening in kids? So straightforward, nice. I like the setup. What were the results?
So we tracked over 32,000 counters where PPI was documented over this 2-year period of time. We tracked the same number of what we call non-exposed patients that didn't receive PPIs during that period of time. And what we found was, interestingly, that patients who had documented exposure to PPIs were in fact at a higher risk for having a fracture in that 2-year period of time. It was an odds ratio of 1.2 to 1, which basically in kind of layman's terms means that our cohort documented that PPI exposure was associated with a 1.2 times greater likelihood of having a fracture during that 2-year period of time. Right.
Wow. That's were you surprised by those results?
Honestly, I was. When I was setting up this project, I was like, this is probably just, I wouldn't be surprised if we didn't see any relationship at all. And it's, there's no increased risk, which I thought would still be useful because a lot of parents want to know, hey, what are the risks of taking this medication? If I could, reassure them, what, from a fracture standpoint, there doesn't appear to be an increased risk, then that would be great as well. So I wasn't afraid of getting a negative result, but yeah, I was a little surprised.
Yeah. So what types of fractures are I'm sure you documented this, right? Like what types of fractures were most common among the PPI group?
So in both groups, both the PPI and non-exposed group, we still see upper extremity fractures predominate. And, as you can imagine, most children, if you look at kind of population data, tend to have, arm fractures, wrist fractures, that type of thing during childhood. So that was consistent with what we found in both groups. But if you broke both groups down and looked at other locations of fractures, we also found that the PPI exposed group was more likely to have lower extremity fractures, spinal fractures, rib fractures as well, which I didn't anticipate that. So for whatever reason, there does appear to be a propensity to have fractures in other locations if you're exposed to a PPI based on our data.
Yeah, that's very interesting, right? You mentioned that there aren't a lot of studies in the pediatric population with PPIs, but I think there are some. How is yours different from maybe some of those other studies?
Yeah, so really, I think to date, there's 3 to 4 other studies that I know about. I think what separated ours is probably, one is the age range. So other studies have tended to either focus on older children or younger children, but not necessarily both. And so we tried to include all because we felt like that was, useful data to see how it affects all groups and if you combine them. The other thing we did was the location of fracture. A more recent study has looked at that, which got published around the same time as ours, but prior to that, nobody had really talked about, if there is an increased risk of fracture, where are the fractures? Are they the same we'd expect? Are they more kind of pathologic fractures? So I think those two separate us out a bit. And then the numbers, having access to the FIS database and the power of getting over 32,000 encounters is a bit unique.
That's pretty good. Yeah, that's pretty good. But what about, all studies have limitations, right? So what were some the limitations of your study?
Yeah, so definitely limitations. Big data is kind of overarching, like looking at the big picture. You don't get some of the granular data like more duration effects and things like that. The biggest weakness I see in it, and hopefully this will get better over time as we use medical records a little more efficiently and they become more accurate, but is that this isn't a closed system. So, for instance, a child who's captured in the FIS database, yes, they may be at a large children's hospital there, but they can go outside of this little bubble of what we're able to capture. They can go to their pediatrician if they have a finger fracture. They could go directly to the orthopedic doctor if they have an arm fracture. So we're only capturing this group in that in these set settings. Additionally, with medications, as you know, a lot of these are prescribed outside of these particular settings, or you can go buy a proton pump inhibitor or histamine blocker over the counter. So I wouldn't be able to necessarily capture those, but hopefully those would, if anything, underestimate our risk or our exposure, but probably affect both groups equally, we would assume.
Yeah. So you mentioned, one of the limitations is duration of exposure to the PPI, right? You didn't really dig down that deep. Is that something you're interested now? And now that you've shown this association to fracture, increased fracture versus that control, is that the next step for you? Dosing of PPI, how long they should be on PPI, is that kind of where you want to go?
I think so. And whether I'll be able to do it in the same manner remains to be seen, or whether you'd have to use a different database or more granular database. I think those are all legitimate questions, because if we're implying that a medication has a certain side effect, well, my next question is, okay, I think it's what the medication they need, but if they need it, what can I do to decrease this risk? And then that becomes exactly as you mentioned, a dose or a duration question.
Yeah, excellent. So, in summary, what would you like pediatricians, GI specialists, community doctors, what would you like for them to know about PPIs in kids?
So I think the first thing I would, want to emphasize is that our data shouldn't be interpreted necessarily as, PPIs causing a fracture. That's not what we set out to do. There seems to be an association, and why that is, as we discussed before, I don't know. And I don't think anyone knows at this point. Secondly, I would say that overall, these medications appear to be, safe as a whole. There's an increased risk of fracture, but if you look at the overall numbers, it's a small increased risk, but nonetheless it's there. So I think they're effective medications, and they can be very helpful to a lot of patients, and we should still be inclined to use them if we need it. But for all providers and for patients alike, we should always be considering whether a patient still needs to be on a medication, and should never leave a medication on their list without truly thinking about over time. Do they still need this? Yes or no? If they don't, how can I safely get that medication off of their list and still make sure that they're being treated appropriately? So I think it also goes to show that, like I said, there is an increased risk, but I think parents should be reassured that this is, a minimal increase, and therefore from a fracture standpoint, if your doctor thinks you need this, I think it's still a safe decision.
Excellent summary. That's Dr. Nathan Fleischman. He's a pediatric gastroenterology fellow at Children's Mercy, Kansas City. Thanks for checking out this episode of Transformational Pediatrics. Please visit childrensmercy.org. That's childrensmercy.org to get connected with Dr. Fleischman or another provider. If you found this podcast helpful, please share it on your social channels, and be sure to check out the entire podcast library for topics of interest to you. And be sure to check back soon for the next podcast. I'm Dr. Mike. Thanks for listening.